Welcome everyone and thanks for tuning in. On this episode we're going to discuss diagnosing bundle branch blocks on the ECG. These can prove difficult, especially for the newer providers, and especially when we start talking about bundle branch blocks in the presence of tachycardia. The faster rhythms can make it a little bit more difficult to know what we're looking at and can make certain people nervous when they're trying to diagnose their patient and they see a wide, fast rhythm going across the monitor. Is this VTach? Is it a bundle branch block? So hopefully after today, this will help you be able to somewhat determine the difference. You can't ever be perfect when we're talking about diagnosing VTach, but we can get you a lot closer. Okay, and here's an example. You look at this ECG, and this can be a little concerning, especially in the presence of a patient who doesn't look so good. And so for a newer provider who doesn't know what they're looking at, this just looks like a mess, just a fast, wide, unknown rhythm. And so this is a normal left bundle. It's a little fast, heart rate's about 140-ish. Now, how did we get there? How do we know that that's a left bundle? I'm going to walk you through what's happening down at the electrical level and how that corresponds to the ECG. So when you're looking at bundle branch blocks, I want you to ignore the hexaxial leads. So you want to focus on these precordials. Specifically, I want you to look at V1 and V6, and that's where we're going to diagnose the bundle branch. V1 and V6 look from opposing viewpoints, and they are going to be able to show us what's happening in the septum, which is where both of the bundle branches lie. And here's a illustration of kind of what you're looking at with the precordials. Now, as a reminder, and I have videos on the basics of ECGs and where all the different leads look at and what's normal, and I recommend you look at those when you get an opportunity. But as a quick reminder, the precordial leads look from a horizontal viewpoint, so that's in contrast to the hexaxial leads, which look from a vertical standpoint, and I talked about that when discussing cardiac axis. These ECG leads look from a horizontal viewpoint, and so wherever you place them on the chest, they look directly posterior from where you place them. And so here's kind of a illustration of what we're looking at. Of course, I've exaggerated the curve a little bit here to show you what I'm talking about, but there's the heart. Now again, from this viewpoint you're looking at, this would be that we were looking down from above the patient, and so V1's over on the right side of the chest, V6 is on the left side of the chest, up underneath the mid-axillary region in the fifth intercostal space. And so what you can see through my terrible illustration here is that V1 and V6 are the ones you're going to focus on because they're almost complete reciprocals of each other. They look from opposing viewpoints at the same phenomenon, and they're going to show us what's happening in not only the cardiac septum, but throughout both ventricles. Okay, and so I've taken just the electrical conduction drawing out of that heart, and I've placed it here, and I've kind of widened it. I've exaggerated things a little bit so that it'll make more sense from a visual standpoint, and I'm going to walk you through what's normal. And so when we're looking at here is V1 and V6 only, and at this point in time the green highlight represents that the atrium has depolarized. And so from V1 and V6 vantage point, that's what your P waves look like. And so V1 is typically biphasic, and V6 P wave usually upright. And this represents atrial depolarization. Okay, now once it gets through the AV node, it's going to hit the bundle of His, and then it's going to hit the bundle branches. And so what happens first? Whenever we do this, the first thing that happens is the left bundle branch depolarizes across the septum towards V1 and depolarizes the right bundle branch. That's a normal patient. And so in V1, you'll see a very small upright R wave, and in V6, a small S wave. You will not always see this in patients. This phenomenon is very small since the cardiac septum is typically very small. Something to always remember is that when we're talking about how tall of a wave we're looking at, one of the factors that's involved in how big of a wave it makes is how much muscle mass in the heart is actually firing. The more muscle mass it's firing, the bigger the wave, the smaller the wave. And so since this cardiac septum typically is a small amount of muscle mass, that event is going to represent very small waves on the ECG, and oftentimes you won't see it at all. But if you do, this is what it'll look like. So once the left bundle branch has innervated the right bundle branch, they both fire simultaneously, and it kind of looks like this. Now, when they fire together in a normal heart, you get a net rightward and leftward movement that's occurring at the same time. And so from V1's vantage point, there's a little bit of electricity moving towards it as the right ventricle depolarizes, but a lot of energy moving away from it as the left ventricle depolarizes. Now this is because the left ventricle is just so much bigger than the right ventricle that it completely washes out anything that you would normally see in the right ventricle when we're dealing with adults. Okay. Now newborns and infants, if you do ECGs on them, and maybe I'll even discuss that in a later episode, they have different ECG patterns, and that's because when you're born, your right ventricle and left ventricle are more equivalent in size, and as we get older, our left ventricle gets bigger and bigger and bigger, and so it dominates what you see on the ECG. And so adults are left ventricular dominant organisms, and so what you typically see is left ventricular activity only. And so since the majority of the electrical energy is being produced in the left ventricle and it's moving from the right to the left or away from V1 and towards V6, just like I talked about in cardiac axis, any depolarization wave moving towards the lead is represented by an upright QRS complex or an upright waveform on the ECG. What you basically see in a normal ECG is V1 should always be negative, V6 should always be positive. Okay, and that's highlighted in green on the drawing. And that's because the left ventricle dominates the ECG, and so what you see is this right to left movement towards V6. Okay, and here's a cross section of a heart that I've labeled for you. Here you can see the difference in the thickness of the walls of both ventricles. So the right ventricle over there is very thin, doesn't hold its shape. The left ventricle is a very, very thick, nice core of muscle mass, and so it's going to produce a significant amount more electricity, typically on average about 80 to 90% more electrical output coming out of the left ventricle. Okay, and here's a completed drawing. So these are normal. Okay, they look a little wide because I can't draw, but in a normal person with no bundle branch block, with no aberrant conduction, the QRS complexes should be narrow, less than 0.12 milliseconds. But basically they should look like what you see on the screen. V1 should be negative, typically with a T wave that's also down with it. And V6 should be a mirror image of that because it's looking from an opposing viewpoint. And so it should have a tall upright R wave and an upright T wave. Any of the leads in between should basically be showing the transition from negative to positive. So you should see an R wave grow as you progress through the V leads. Okay, here's an exact example of what I'm talking about. So if you look here, and again, this is still not even a bundle branch, this is a normal presentation. You notice that V1 is negative, V6 is upright, and then if you count down from V2, V3, V4, V5, V6, you notice that the R wave just gets bigger and bigger and bigger. And somewhere around V4, we transition from being negative to being positive. That's why V3 and V4 are typically called transitional leads, because the QRS complex, is transitioning from negative to positive, and you can see that here. So there's no R wave present in V1, then there's a little bit of an R wave in V2, it's getting bigger in V3, it's now transitioned to isoelectric, maybe tipping the scales over to being positive. V5 is clearly positive, and V6 you have almost no S wave left, it's almost completely upright, and your T wave is upright. And so that is a normal presentation. Okay, so let's look at what happens when we incorporate a bundle branch block into that ECG presentation. Okay, so the first one here, this one could look ugly, especially to a novice. This is a right bundle branch block. Now, how do I know that? What is happening here electrically inside the heart to make this presentation? You notice we have a upright QRS in V1, which is completely opposite of what it's supposed to be. Remember, V1 is supposed to be negative, V2 is supposed to be negative. When I look at the precordials, all of them are positive. And that's something to tip you off that you might be dealing with a right bundle, is that in a true complete right bundle branch, V1, V2, V3, all the way through, almost all of them should be positive, which should catch your eye right off the bat. Okay, so back to the drawing, we've got our electrical conduction system here. So in V1 and V6, those are the only leads we're going to look at. We can ignore the other ones for diagnosis. I've created a right bundle here. And so remember, when the bundle branch is depolarized, the first thing that happens is that left bundle branch comes over and innervates the right bundle. And so in this case, it's blocked, it can't be innervated. And so we still get that septal depolarization that's normal. And remember, that is a small R wave in V1, a small S wave in V6. Then the left bundle branch depolarizes normally, and so you get left ventricular depolarization. Okay? Now this is normal depolarization, so it occurs on a scale that's normal. There's nothing out of the ordinary with the way the left ventricle depolarizes in a right bundle branch block. So the electrical conduction is transmitted through the conductive network, which is an extremely efficient way of transmitting electrical activity. That's why we have it developed in our hearts, is so that it can conduct these signals in a very efficient and fast pattern. And so it does, and it moves towards V6, and so you have an upright in V6 and a small S wave in V1. Now, after that happens, something unusual happens. This is where the aberrancy is created. So cardiac cells, in the absence of pacemaker cell conduction, do have the ability to conduct cell to cell. The muscle cells can innervate themselves. Now, when they do this, this is an inefficient method of transmitting electrical activity, and so it takes longer, and it happens on a magnitude much greater than if you were to have used the conductive network. And so what you end up with in V1, because it's closest to the right ventricle, you're going to end up with this a much taller R wave on the second time through. So there's already an R wave here, and so now we have a second peak, a second R wave, and we term that R prime, or you'll sometimes see it annotated with just an R and a dash above it. And then you have a small S wave in V6 because that late depolarization of the right ventricle is occurring after the left ventricle is already depolarized, and that electrical activity is coming back against itself, cell to cell through the muscles, to hit the right ventricle. And so since it's now moving towards V1, that depolarization is moving towards V1, that's going to be reflected as an upright R wave in V1. Then in this case, it'll be R prime again, because it is a second R wave, and an S wave in V6. Okay, those three things that I just described are the classic presentation for a right bundle, and they're the criteria that you need to diagnose a complete right bundle. The QRS has to be wide, so greater than 0.12 milliseconds. It has to be overall positive in V1, and it must have an S wave, sometimes termed a slurred S wave, in V6. It must have all three of those criteria in order to be deemed a right bundle. And so if it's missing any of those things, it's either an incomplete right bundle, or it's what we would term a nonspecific idioventricular conduction delay, which is just a long word to say it's some sort of aberrant conduction, but we don't know what it is. It's not a right or a left bundle. Okay, so it has to meet exact criteria to be termed either a right or left bundle. Okay, and there's the morphologies you'll see. Now, anytime you have an aberrantly conducted depolarization, you typically run the risk of developing flipped T waves. So always look for discordant T waves or flipped T waves. They don't have to occur in every lead, but it is very common when you have an abnormal depolarization, you predispose that ECG to having flipped T waves. And here's a pictorial comparing that. Basically, it's showing you my drawing compared to the ECG pattern, so you can actually see with a good example what we're looking at. And so if you zero in for a second on the true ECG, and if you look at V1, you can see you have a small R wave followed by a small S wave, and then a second larger R wave called R prime, and then you have that slurred S wave in V6. And then if you were to measure those QRS complexes out, they would be greater than 0.12 milliseconds. So this is a classic true right bundle branch. That second big R wave represents late right ventricular depolarization occurring after the fact, indicating a lack or a loss of conduction through the right bundle branch. Okay, so let's look at this one. It's not upright in V1, so we can already rule out right bundle. So it's down, which is accurate for what we typically look at. V1's supposed to be negative. Now, if you look at this, V1's negative, V2's negative, V3 is less negative. That's a little more normal, following the pattern that we'd expect, and it transitions to positive. But it's wide, and you have all these discordant T waves. So this is a classic left bundle branch. And again, out of the two, these can be the uglier of the two. They typically correlate more with heart disease, especially since the left ventricle is much more affected by heart disease. And so people who develop late stage heart disease are very prone to having left bundles and can have very ugly ECGs. So how do we get there? Why do we see that pattern in a left bundle? Well, if we review that the left bundle typically starts the process of depolarization in the septum, in a block of the left bundle branch, what we're left with is basically the right ventricle will depolarize down the right bundle branch very quickly, and to low magnitude. And then what we're left with is this deep S wave in V1 and a tall R wave in V6. And what's happening is you have cell-to-cell depolarization of the left ventricle, and it's abnormally conducted. So rather than using our conductive network, it basically uses a large portion of the cardiac myocytes. And because of that, you get this high amplitude QRS complex. So in V1, it's going to be a very deep S wave, and in V6, it can be a very tall upright QRS. Doesn't have to be, depending on the patient's physiology and underlying comorbidities. There's various presentations you can see, but what you're looking for when you want to diagnose a left bundle is that, just like a right, it has to be wide, so the QRS has to be greater than 0.12 milliseconds. You have to have a deep S wave in V1 and an R wave present in V6. So they'll sometimes term it that the RS ratio has to be greater than 1. That's just a fancy way of saying that you have to have an overall positive QRS complex in V6. And so what you'll see a lot of times in V6 is a notched, or what we call an M pattern, which I've drawn here in my illustration. You do not have to have that, but you can see that from time to time. What you're looking for diagnosis, again, is a deep S wave in V1, an upright R wave in V6 that is greater than 0.12 milliseconds. Okay, and here's a side-by-side comparison. You can see with the example I gave you, we looked at V1, it's deep S wave, it's greater than 0.12 milliseconds. V6, you have a little bit of a notching pattern, but you don't have that classic M pattern, but it is wide, it is upright. And like all the bundle branches, you're at risk of flip T waves, and you see that here, especially in V1 and V6. You have flipping of the T waves. That is just an indication. In this instance, it's just an indication that you have a aberrantly conducted complex. It's not a sign of ischemia in this case. It is a sign that your depolarization wave was conducted abnormally, and that flips your T wave. And I can do an episode later explaining exactly why we get flipped T waves in these cases. Okay, so let's practice a couple examples here. So take a look at this one, evaluate it. Again, remember, you're looking at V1 and V6 only. You can ignore the rest for now, and take a look at it and see what you see. As you start to analyze it and you look at V1, you're going to note that it's overall positive. It's greater than 0.12 milliseconds. I have an R and an R prime, with R prime being bigger, and a flip T wave. Or I'm sorry, actually that's correct. V1 should always have a downward T wave if possible. V6, you've got a wide QRS, you got an upright QRS complex, and you have the presence of a slurred S wave. And so this is going to be a right bundle branch block. Okay, here's another example. Take a second if you want. You can pause the video. look at it, observe V1 and V6, and you see, again, very similar pattern. You have upright QRS that's wide in V1 with an R and an R prime, and a slurred S wave in V6. This is your classic, and you can look at V1, V2, V3, all of them are upright. That's your classic right bundle branch block. Things to look for, patients who develop right bundle branch blocks, by the way, respiratory patients are very prone to developing right bundle branch blocks, especially chronic respiratory patients. The reason behind that is that right bundle moves through the right ventricle very close to the endocardium. And so anytime somebody develops increased right ventricular filling pressures, it can mechanically compress the right bundle and cause a right bundle branch block. Okay, so if you start paying attention to it, what you'll notice is these chronic COPD patients, or these people who have classic chronic pulmonary hypertension, are very prone to developing right bundle branch blocks on the ECG. But anything that increases right ventricular filling pressures can create a right bundle branch block. And so, not that it's the most common ECG presentation, but pulmonary embolism could cause a right bundle branch block. Any patient where you have increased pulmonary pressures is a one type of patient. And so they do say a lot that I've heard people say that, oh, right bundle branches are benign, and they can very well be benign. But if you have an old ECG and you know the patient didn't have a right bundle to begin with, and they come in distress, elevated pulmonary arterial pressure should be, or excuse me, at least elevated right ventricular filling pressure should be somewhere in your differential as far as a cause for that presentation. Okay, so this is a somewhat ugly looking ECG. You can focus in on V1 and V6. And again, pause the video for a second if you're wanting to try to guess on your own. You have a wide QRS. You have a deep S wave with a upright T in V1. You have a upright QRS complex in V6 with a little bit of a notching pattern and a flip T. This is your classic left bundle branch block pattern. Okay, and for those looking at this and seeing a bunch of ST elevation and being concerned that maybe this patient's having infarction, this is a normal presentation, and I have a whole video dedicated to looking at aberrantly conducted complexes like left bundles and applying criteria to determine if the patient's having an acute MI. I highly recommend that for helping you to find STEMIs in these kinds of patients, because especially left bundle branch blocks can present with inherent ST elevation that is benign and normal for them, and does not mean that they're having an infarction. And you need to be able to tell the difference in these patients, because they're clearly at higher risk. If they have a left bundle, the probability that they have some sort of cardiac disease is much higher, and thus they're at much higher risk of having an acute infarction. Okay, here's another example. It's a little bit faster. Again, heart rate around 140. Hard to even tell where the J point is. So again, I recommend that video I made on this, because it would be, some people could see this and be concerned. But take a moment, take a look at it, and take your guess. Okay, so we have a downwards QRS in V1 that's wide with a flip T, and you have the opposite in V6. Okay, so this is a classic left bundle branch block morphology. And also too, I want to stress that I do believe it's important to fundamentally understand why these ECG presentations manifest in this type of pattern, and that we don't just learn little tricks. I've heard a couple of tricks about trying to learn bundle branch blocks, and none of those are 100% accurate, and you're going to miss stuff, you're going to misdiagnose stuff. The most common one I've heard is that you're driving along the ST segment, and if you have to turn in a fictitious car and you have to turn right or left, that'll help you to determine if it's a left or right bundle. That's not 100% accurate. So that will be right some of the times. This would be a case where it would be very difficult to even make that determination, because the ST segment does not return to the isoelectric line. It doesn't involve using V6, which it should, because it has to have both to meet criteria. And again, just like most things, I don't teach the tricks because I feel like it robs the provider of learning comprehensively what's actually happening in the patient. And when we start comparing these to try to determine whether this patient might, especially when these get fast, if we're trying to compare these between VTAC and either a left or right bundle branch block, it's imperative that you understand in detail which is which, because the VTACs will mimic these bundle branch blocks, and there's only subtle differences to help you determine which is which, and that can be important when we start talking about treatment of a tachyarrhythmia. Okay, here's another example. Go ahead, pause the video if you don't want me to give away the answer too quickly. You have a upright in V1 with an R and an R prime, and a downward T wave. All the precordials are positive. V6 is positive and wide with a slurred S wave, classic right bundle branch. Okay, another example, downward QRS complex in V1 that is wide, upright in V6. There is an up slurring, but not the classic M pattern that you might see. But again, this is a left bundle branch block. Okay, hopefully you're starting to get these. This is the last example. I want you to take a look at this for a second. Pause the video before I give it away. And so in V1, we note downward QRS. It's negative, it's wide, not quite the presentation we've been looking at in previous ones, but you note wide, deep S waves in the precordials. You look at V6, and it doesn't come back. All of the precordials, in fact, are negative. Okay, so you do have a notching pattern in V6, but it's negative. It should be upright to be a left bundle. So this isn't a left bundle. This is one where if you use that trick that I was just discussing a few slides ago about driving down the ST segment, it would lead you astray. This is an idioventricular rhythm mimicking what we would call it. This is what we call a pseudo left bundle pattern. And so in this patient, if this was fast and you just assumed it was a left bundle, you might miss, because if we accelerate, if this is an idioventricular complex and we accelerate it too fast, then that would make it monomorphic VTAC, in which case your treatment regimen pharmaceutically would change. Okay, and I've zeroed in here on this slide to show you where it fails. The red circle indicates that should be positive and upright in order to meet true left bundle criteria. Okay, I hope that helped kind of shed some light on bundle branch blocks and how to diagnose them on the ECG. Thanks for watching.